Good morning. Thank you so much, Calcivis, for having me and for you to be here. Can you hear me again? Okay. And here, all right. So I'm going to give you a U.S. perspective on what Dr. Pitts and Dr. Banerjee has just discussed, and it has been an interesting process there. I think every time a clinician looks at an image like this or is doing a clinical examination, they're trying to decide what should they do with this tooth here. And they're trying to decide if this is a lesion, if it is a lesion that is going to progress, is it active or inactive? What kind of treatment should they do? What is the prognosis? And that, as the two speakers have just discussed, will really depend a lot on how they were trained, what kind of experience they have, what kind of system they're working in, what kind of compensation model they have. And there has been a lot of attempts to change that, and there has been a lot of hurdles to do this. But as you can see here, not all surfaces are going to cavitate. And I need to... There you go. So if you may, here? You may have thought that a lot of times I ask this in audiences, which surface is going to cavitate, and people think it's this one. But it's actually this one that cavitated at 4 years. So dentists really need to have something else to help them decide what is the prognosis for a surface and how to help them decide what they should do to each surface, which one is more likely to progress. As we have just heard, how dentists are taught plays a big role. In the U.S., cariology has received lately more attention than it did in the past. We did a survey back in 2012, and we identified that although many schools, or most schools, were doing caries risk assessment, several schools were teaching students something else in addition to visual examination and radiograph examination. Only about half of them were telling students how to actually chart caries activity, and many of them were discussing several products that were being used in the clinic. But the biggest issue has been, what is the threshold that you actually intervene when there is a lesion? When do you start the intervention, a restorative intervention? When should you do a preventive intervention? There has been a lot of great variations on what they use. And their biggest concern has been that what is taught in the didactic part of the curriculum doesn't get implemented in the clinical portion of the curriculum. So this was found as a big issue back in 2012, and then a consensus workshop was developed, and there has been many schools, where 73 participants of 35 U.S. dental schools collaborated on that and developed this a consensus of a core curriculum framework for teaching cariology in the U.S. This was published in 2016. And we did a new survey last year, and what we have identified is that there has been a lot of issues trying to implement this curriculum in the clinics. And we are having a new workshop focusing on the implementation of the cariology curriculum next year in 2019, with an effort from the IDEA, which is the American Dental Educators Association, the European Organization for Caries Research, and the American Academy of Cariology. So we're hoping that this at least helps on this end of the education of dental students, so that they can start thinking that right from the beginning, and we are starting to work with the educators as well. And this is definitely very important, because in the States, there is still a lot of dental caries. We have it's the most prevalent childhood disease. It beats asthma. So many kids, and you can see that by 19 years of age, 2/3 of the children or adolescents will already have disease. By the time you reach 65, 96% of the population will have experienced dental caries. So it is a significant issue, and not not only a significant issue of prevalence, it's also a significant issue that a lot of those lesions are still considered are untreated. They are left untreated. We homage to Dr. Pitts, can we look at the behavior of the lesions and predict that? We know that not everything that we see, like the iceberg, is what is present, that there is a lot of disease that is unseen, but it's there, and we know that they are can progress to cavitation, but it's that threshold that we don't know where it is and which ones of them are of importance to treat, or to manage, or to intervene. So there was some studies that we did in the past that looked at the natural history of dental caries and trying to identify when is that a lesion becomes cavitated and which lesions do become cavitated. And what we did find is that depending on what you found in the early stages, it might be more prevalent, the progression would be more prevalent than not. But our ability to determine if it was active or inactive, and this was so the lesions that we considered active or inactive that did not cavitate. So you can see, especially on the ICDAS 1 and 2, which was the very early stages of dental caries, even though we thought they were active, some of them never did progress to cavitation. And some of lesions that we considered inactive did progress to cavitation. So our ability to determine this is still very subjective. And it really, to predict what a lesion is going to, how it's going to behave, it's a little bit like finding a needle in a haystack, because we don't know which ones are going to progress and which ones are not. We have some suggestions and looking at caries risk, but it's still very subjective process. And it hasn't changed much. Dr. Pitts discussed about Dr. Bakker-Dix, and it hasn't changed much. If we look at it, lesions back in '66, 4% of the class 5 progressed, and it's a little harder to find those now because it's only 1%. For lesions that were initial, again, it's a little bit harder to identify them because less of them are progressing to cavitation. And we can see that what happens a lot is that lesions are oscillating. They become, they look like they're progressing, and then they are not progressing anymore. And you find this in this study here that looked, and some of them reversed. So to try to identify which one is actually going to progress, it's very hard. All of these studies, they didn't have any intervention that was meant to. They may have had intervention, but not for the study purpose. Okay. There is a lot of caries detection aids, and there are lots have been discussed here in this meeting and several other meetings before that are trying to help dentists have a little bit less subjectivity on the assessment. And I do think that ICDAS also looked at trying to have a little bit less subjectivity to the assessment. And there are many methods and many methods that have been in the market, and some are easier, some are harder to use. But all of them are trying to put in a little bit less subjectivity and trying to help the dentist determine are lesions progressing or not. With one of these methods, the QLF, we looked at the same data that we presented just before, and we did find that the lesions that were not progressing had a more flat, flat regression line in terms of one of the criteria, which was loss of fluorescence. And the lesions that did progress did incline and changes those values a lot faster. So this, can be helpful, but you need to follow up the lesions to know what was going on. And dentists, tend to have a very strict protocol. Many of them is, every 6 months they see the patient, brush better, don't eat sweets, put some fluoride gel, and send them on their way. It has changed some, but it hasn't changed completely. So there's still many dentists across in the United States that still have the 6 months protocol for all patients independent of caries risk. Dental sealants are still not used very frequently in the States. You can see that less than 50% of the population of children and teenagers will have sealants. Although fluoridation is, water fluoridation is very prevalent, it still has many communities that are not fluoridated and some populations that don't have access to fluoride. And there's still a lot of dentists that are very aggressive on their treatment. This is from 2011, but these images were sent out around dentists in the States, and they were looked at, and many lesion surfaces that were considered sound or to have a very initial lesion still would be considered to be restored. Almost 50% of dentists would decide to restore. There has been, I think, a great thought process is if we restore, you were preventing the disease or you were not going to allow the disease to progress. This is something that I hear a lot from clinicians, that they are very concerned about not intervening surgically and having an issue of a lesion progressing, and how that will be seen even with lawsuits against the patient of malpractice. And it's clear that just following up lesions is not, and restoring, as Dr. Banerjee just discussed a lot, you are seeing patients that are going to the dentist but still getting progression of lesions and just getting more and more fillings. So I do believe that we can't really dig ourselves out of this hole, or better, we can't really drill ourselves out of this hole. We really need to have something that is minimal intervention and prevention of this disease.
David, you have one of the worst cavities I have ever seen. Okay, have a good day.
Aren't you gonna fix it?
Well, I'm not a dentist, I'm a dental monitor. I just tell you when you have a bad cavity.
It's bad. Lunch?
Oh, yes.
Where are you going?
Why monitor a problem if you don't fix it?
This, and I just clipped, and it's saying, I just find I found this cavity. It's a really large cavity, and the patient with his mouth full of cotton says, aren't you going to fix it? And he says, no, I'm just a monitor. I just monitor. I don't fix it. And in the States, a lot of what dentists will mark is chart a lesion, and what are you doing? We're just going to watch this lesion or monitor, but no intervention is done, or no. So it's either they are doing a restorative intervention or they are watching. And so I thought that was appropriate, because you don't want to monitor a problem if they don't fix it. You actually don't to fix it, not restoratively, but in a means of intervening and changing the disease process there. So some of the things, and this has Dr. Pitts discussed with the ICCMS, is looking at primary preventive care, aims to prevent new lesions, secondary preventive care, aiming to prevent progression of existing lesions, and non-operative care of lesions. And then tertiary preventive care would be to aim the preventing more loss and really preserving tooth structure at all steps. So of course this is all would be including to identifying risk and risk factors, and playing the role of the risk would be, it's important for the successful outcome. You can't do anything if you don't have the risk. And as we discussed before, we can't drill ourselves out of this role because there is a very limited longevity of all those restorations. So in terms, it has changed. We have a lot more interest in this. There is a lot more traction, I believe, in the United States in terms of interest in prevention. And it has been led by having more products available. And we have some new codes that are available now that are helping dentists in terms of being able to charge for some of these activities. So if you have a sound surface, we would look at having a low risk fluoride, for moderate risk fluoride at a higher levels, professional care, increasing the the use of fluoride varnish and increasing use of sealants. So hopefully this is getting more interest. And then there are several other products that are available and thinking about modifying diet and behavior in terms of looking at prevention. And there are several, how do you say, lost the word here, but there are several entities that are looking to help dentists, and we can see more traction on interest in doing primary prevention. Secondary preventive care is risk-based, also looking at when there is already a lesion. And the goal, of course, would be to remineralize or arrest this lesion, and there are several methods that you could do that. Would be to arrest, removing biofilm or modifying the biofilm, changing the environment by placing a sealant, remineralizing the lesion or arresting the lesion are options. And it doesn't really change very much of what we are able to do, how we are able to do this. Again, we are looking at fluoride, at increased levels of fluoride, either in home care or professional care, of course, sealants, and then when we have a lesion, we have infiltrants, and in United States, SDF was approved not many years ago. We just had a second product introduced just a couple of months ago. So it's slowly getting more traction for different things and has gotten quite a bit of interest on these new products. And of course, we also have to look at other products that would be available to help. And evidence of all these products, there are different levels of evidence that the dentist should be looking at. But there are options, but we do need to know where and what to use and which surfaces would be better served by each of these methods. So I think, if we try to look at looking at what's going to happen in the future and go back to J.V. Black in '86, I don't need to read here, but he's saying that there will be a day when we maybe will be practicing preventive dentistry. And I really hope that this is now that we have arrived there. Thank you very much.
Thank you.